Mississippi ranks at the bottom for overall health, obesity, heart disease, diabetes, and preventable hospitalizations. More than half of Mississippi's 3 million citizens live in a rural community, and almost a quarter live at or below the federal poverty level. 2/3 of Mississippi's hospitals are located in rural areas and lack sufficient resources in specialty care. But despite these facts, telehealth in our state is increasing access to health care and improving outcomes and lowering cost. The UMMC Center for Telehealth began in 2003 with the Telemergency program connecting critical access hospital emergency departments to physicians at our trauma center. 12 years later, telehealth allows us to provide over 35 medical specialties to 166 sites around the state, including community hospitals and clinics, mental health facilities, schools and colleges, corporations, prisons, and even in the patient's home. We connect to sites in 52 of the state's 82 counties and serve an average of 8,000 patients a month. Since 2003, we have been awarded over $9.7 million in federal grants to purchase devices, conduct workforce training, and enable the technology that we use to serve patients daily. This early funding allowed us to test delivery systems, areas of practice, and service locations in order to craft an effective and impactful model worth replicating. Without early critical support from HRSA, FCC, and others, our network would have been very slow to deploy, taking the longest to reach those with the most need. Today, our system is completely self-sustaining. A critical factor to our continued sustainability is the reimbursement parity available in Mississippi. Prior to 2013, insurance companies in Mississippi did not reimburse for telehealth services. We argued that Mississippi would ultimately save money if they did and undertook a series of pilot projects to prove it. We were successful. In 2013 and 2014, Governor Bryant signed legislation mandating that health insurance companies reimburse for telehealth services at the same rate as in-person services. These policy changes were the catalyst for the rapid growth of our system. While increased reimbursement may cost more in the short term, years of data from our state and numerous others prove that the cost savings achieved through better chronic disease management, fewer ER visits, and aggressive preventive care far outweigh the expenditures. Given the success that we have seen in Mississippi, I can only imagine the exponential impact of offering similar federal parity for telehealth. I commend CMS for opening new code sections for reimbursement and hope the committee will encourage them to expand coverage for more services in more communities, be they rural or urban. Without reliable connectivity, we cannot serve rural patients. Thanks to support from Universal Service Funds and our telecom partners, we are able to bring much-needed health care to rural Mississippi. It is this connectivity enabling remote patient monitoring in the home that is changing lives in ruralville, Mississippi. Last fall, we launched a research pilot aimed at managing 200 uncontrolled diabetics through aggressive in-home monitoring and intervention. Once enrolled, patients are sent home with an electronic tablet that monitors glucose readings daily, provides educational information, and transmits health data to specialists monitoring them hundreds of miles away. For the first time, these patients have access to a medical team dedicated to their care: ophthalmologists, endocrinologists, pharmacists, nutritionists, diabetic educators, and nurses. Preliminary results show that the majority of patients have already met or exceeded the goals that were set for the end of the study. With one exception, none of our patients have gone to the ER or have been admitted to the hospital for their diabetes. The results are improved care at a reduced cost. So we look forward to working with the committee and would like you to consider these few points. The need to test reimbursement parity at the federal level, particularly for remote patient applications. The only way for us to know if the success of pilots like ours can be replicated at the federal level is to test it. Now is the time for CMS to pilot new reimbursement parity models for telehealth, especially in-home monitoring where impact is the greatest. The need for continued coordinated federal support for telehealth. While our network has become self-sustaining, it will not be complete until we reach every Mississippian. The need for federal funding remains, and efforts to coordinate opportunities across the agencies should be encouraged. The need to remove geographic barriers for reimbursement. Rural or urban, telehealth is a powerful tool in improving access to care and should be incentivized. We recommend that geographic restrictions for CMS reimbursement be removed. And then lastly, the need for continued support for universal service funds. A reduction in any of the USF funding will not only impact current operations, but will significantly hinder our efforts to offer remote patient monitoring in rural communities. Funding should be protected. Our mission is to increase access to health care, improve outcomes, and reduce cost. Telehealth allows that to happen.
Dr. Henderson, my last question would be on telemedicine. Are you getting reimbursed for, do you have behavioral health also?
We do, yes.
And are you being reimbursed for behavioral health in the same way you would be for all other health items?
We are.
And your goal is to recapture all cost?
Correct, and to integrate behavioral health into medical clinics as well.
Do you have any studies yet that would indicate how much better people do with their other health problems if you're dealing with their behavioral health problems at the same time?
Well, you know, it's interesting in our diabetes program, a component of our program is around medical adherence and lifestyle and behavior changes, which needs a strong mental health component as well for behavior change. And so we're incorporating into that. We're not through with that study yet to be able to publish it, but we're offering now mental health services even on college campuses and in schools. So it's one that will continue to grow, and it's probably one of our biggest demand right now.